Exercise testing in Wolff-Parkinson-White syndrome. So Wolff-Parkinson-White syndrome, that is WPW syndrome, is a WPW syndrome is a pre-excitation syndrome. So what happens in WPW is, supposing this is your heart and this is the right atrium and this is the sinus node. This is the left atrium, and this is the left ventricle. So in pre-excitation, what is happens is normally the conduction pathway goes from the sinus node, this is SA node, to AV node. So it goes to the AV node. From AV node, it comes down to bundle of phase and it goes down to bundle branches and all. So now in this patient, because of this, suppose there is normal conduction, you get P followed by a QRS. So because of ventricular depolarization, and this is the atrial depolarization. Now supposing patient has some additional pathway, usually in case of WPW syndrome is called as bundle of Kent. So suppose there is accessory pathway and the conduction is going down from here as well. Usually the conduction through this accessory pathway is usually bidirectional. What do you mean by bidirectional is that the pathway conduction can go both downwards as well as upwards. But usually in case of WPW syndrome, it is bidirectional followed by retrograde. Only antegrade is very rare. So what happens is the normal pathway will be through the AV node and some retrograde pathway go from here to the accessory pathway. And thus it leads to AV re-entrant tachycardia. Because there is a re-entry from the accessory pathway, that's why it is called as re-entry tachycardia, and patient may lead into arrhythmias. So since there is a also there is both, I said most common is bidirectional. There is early, what is there is early can go from here as well. So patient initially will have P and there will be very short PR interval because the time taken for atria to ventricle to reach is very less because of this accessory pathway, and thus patient will have a delta wave like this. So this is the delta wave which you can see here. So now why do you want to do exercise testing in WPW syndrome is that you want to assess whether this patient has any risk of, so as I already described that all these WPW patients are a very high risk of arrhythmias, most commonly AV reentrant tachycardia, that is AVRT or supraventricular tachycardia. Patient can also develop atrial fibrillations in this patient. So to assess that thing, we need to do exercise testing here. So basically, we do exercise testing to risk stratification to identify any high-risk accessory pathways that may lead to life-threatening arrhythmias such as ventricular fibrillation or rapid AF. So you want to know that whether this patient of WPW syndrome you routinely see during your OPD or anywhere, you must have seen a patient with WPW or a pre-excitation. So do all patients need to be evaluated or need a defibrillator therapy? No. So we need to assess their risk. So how do we assess is that? So we need to find out whether there is high risk accessory pathways. Or suppose that patient is of WPW is made to do exercise and during exercise patient develops a rapid atrial fibrillation or a ventricular fibrillation. That means that there is a very high risk of sudden cardiac death and that this patient will require the ICD therapy. So most important parameter which is measured is the RR interval. So suppose patient is developing AF and this is the QRS and this is the QRS again and this is the QRS again. So this is some long segment, here it is short. Suppose this RR interval is less than 250 milliseconds during the exercise. If this is less than 250 during exercise anywhere, this has a high risk of arrhythmia chances. So this patient, if any patient developing during exercise less than 250 milliseconds of RR interval with AF, you have a high risk of what is called as progression to life-threatening arrhythmias, and later on can progress into ventricular fibrillation as well. So other indication is basically to see the symptom burden. So we want to see that during exercise when patient has developed any symptoms, suppose patient is developing a palpitation or syncope during exercise. So what ECG changes are there during that time, we want to assess by exercise testing. So if the ECG changes and this palpitation syncope both are together, comes together, then that means that it is life threatening and patient needs evaluation and therapy. Important thing is they say that suppose a patient was having a delta wave. So this is a delta wave is there, and during exercise, if the delta wave disappears, that is a good sign, and patient has very less chances of arrhythmias in that patient, and patient does not require very other therapy. Only observation is required. And patients with persistent delta waves and evidence of rapid conduction, as evident by, as I said, that if the RR interval is less than 250 milliseconds, that is less than around 6 small squares, then the patient is called to have a high risk of atrial fibrillation or arrhythmias. So also we want to do exercise testing in any patients. Sorry. So any patient or person who are going for a competitive sports, we want to assess the risk of arrhythmias or death in that patient. So we definitely do what is called as exercise testing in those patient of WPW syndrome, because we want to see that whether the patient is able to handle the stress or not. So findings and their implications. Suppose there is loss of delta wave during exercise. So if delta wave is absent during exercise, that means that it's a good sign. This patient may not require any further intervention. Suppose persistence of pre-excitation, that means the delta wave are persisted. It indicates a very high risk pathway and may require further evaluation in form of electrophysiological study and may be considered for catheter ablation. And suppose during exercise patient develop arrhythmias like premature ventricular contraction AF, it suggests a need for further risk stratification and possibly intervention for that patient. So when do you consider catheter ablation in this patient is that